The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to Lymphcast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show Lymphcast.
Today's Lymphcast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our Lymphcast show, episode 32 tonight. We are glad that you are with us, and we can be found everywhere. We are on YouTube. Every episode is there. We hope you check it out. We're also on every podcast platform under the sun: Apple Podcasts, Google Podcasts, Spotify, Apple Music, Apple/Audible, Podbean, Deezer. We are everywhere, so you can find us. And also check out our website, lymphcastnetwork.com. That's lymphcastnetwork.com. Everything is there for you. In addition to that, we want to hear from you. What do you want the doctors to answer? Send in your questions to this email address, hello@lymphcastnetwork.com. That's hello@lymphcastnetwork.com. Now let's go ahead and meet our panel tonight. From New York, RVT, Jacqueline Sasick. Hello, Jacqueline. How are you today?
Well, thanks. How are you doing?
Doing well. Glad you are with us. Hello, Dr. Glovitsky. How are you?
Thank you very much. I'm doing very well. And actually, I brought Arizona now to Poland. So I'm speaking with you from Poland.
All right. Very good. The founder of VitaSupport MD, they make Vein Formula 1000 and Lymphatic Formula 1000. He's also the founder of this Lymphcast show. From New Jersey, physician surgeon, Dr. John A. Chubak. Hello, Dr. Chubak. How are you?
I'm doing fine, Paul. Thank you so much. Good to see you again. And hopefully Monica can bring a small bucket of that rain back to Arizona with her when she goes. They could use it.
That would be good for our Arizonan earth, you know. Well, I will maybe go straight forward to introduce our guest of honor, because this guest of honor is particular for me. This is a really a good friend of mine and my husband's. And we are talking about Dr. Linda Austin, who is close to vascular world paralliance, as you could say in French, because she is married to a very famous vascular surgeon, but Linda has no other connection to vascular world and no connection to lymphedema. I wanted to say that we invited Linda with that idea. Linda is a psychiatrist, and Linda had a lot of experience with treating the patients with the chronic somatic diseases. And in that regard, actual lymphedema or other chronic disease has this in common that is something, you know, they are to be taken just as a chronic debilitating condition. And I had this pleasure and privilege to convince Linda to help us to answer the question of many physicians, certainly, and many patients, how to deal with the diagnosis of lymphedema. And I let you maybe talk a little bit more, Linda, about yourself and your view of this issue.
Well, first of all, thank you so much for inviting me, Monica. What a pleasure to be with you all. And it is true that though I am not a vascular surgeon, my husband is a vascular surgeon, and I have been to many vascular meetings and probably know more about vascular than many psychiatrists do for for that reason. So I'm really delighted to be with you. I think the way I think about this is that human beings are whomever they are, first and foremost, and secondarily, they are someone who is suffering from an illness. I have my own podcast series, and I recently did a program about how to talk to people with cancer. And the woman who was a 17-year cancer survivor said, she said, I get so tired of people walking up to me and saying, Mindy, how are you? She said, I just want to be Mindy. And in the cases that we're going to talk about today, there are 3 hypothetical cases of 3 very different people. But I want to underline, both for the clinicians and for any patient or patient's family who may be watching, that person with lymphedema is first and foremost, let's say, a 16-year-old girl, or a mom with kids, or a man struggling with addiction. And then on top of that, they are dealing with a very serious, chronic, potentially disfiguring, potentially debilitating illness. But so I'm underlining that we first need to think of these folks as who they are as they're living their lives, and then what does their illness mean to them in the context of their daily lives. Does that make sense?
Absolutely. So maybe we should continue with that first hypothetical case of a young girl. And actually, we certainly have among our lymphedema patients that we know the cases like this. Young girl, beautiful, normal, and suddenly something is happening, and she is told you have lymphedema, and how to present, because truly this is a double facet for me of the diagnosis. First of all, you don't want to underscore the importance of this disease, right? And on the other side, you don't want to crush your patient with the too serious approach and too catastrophic vision.
Yes, and yet the reality may well be that this will be a very chronic condition. And that's tough. And this is an era, of course, when anyone can look anything up online. So no matter what you say, that person will look things up online, or maybe will not. People really vary a lot as to how much information they really want to need. And that might be one of the first things that I would think about, which is there are those people who want to know everything. Especially, I think, as folks get older. With a 16-year-old, let's say, maybe not so much. But still, I mean, if I think of myself at 16, I probably would have wanted to know a lot. I would have a lot of questions. Others don't want it. There are those patients who need to stay in denial. And if they are in denial, I would say to respect that and not beat that down, because they may need that defense. They do need that defense if that's what they're dealing with. But I think the first thing to begin to try to suss out is how much information does that person need. So just to think about what is unique about teenagers. Teenagers are in a very different world. They are not children anymore, but they certainly are not adults anymore. They are less adult than they think they are. I mean, they are leaving childhood behind, but their level of maturity is still pretty limited. And for a teenager, having friends is everything. It is the single most important thing in the life of a teenager. And teenagers build their friendships by being like everyone else and wanting to be liked by everyone else. And so in that context, what does this diagnosis mean? It may mean something very different than, let's say, if you're 55-year-old man, where those issues are not so important. But for a young girl, issues of body image are really important. So to be aware of that and to be sensitive to that is really important. I always think that the number one rule is to listen, to give some information and sit back, let there be some quiet time, and just listen and hear what the questions are. Give time for those questions and hear where it goes. Then my husband and I were actually talking about this before the podcast today, and he emphasized how even when with lymphedema patients, if what you can do is not as heroic as you would like, if you cannot say, "Oh yeah, we can fix this for you," if they're asking, and you may have to give the news that this is a chronic condition, to be empathic, to be available, and to not go away is really important. To give the message that I am your champion, I am sticking with you. We're going to get to know each other well over time. You're going to have lots of questions. I'm going to help you do the best possible job we can in managing this. But that is a wonderful message to give, and I think that's really key for a patient of any age. I'm interested in hearing from each of you, though, what your experiences are with the teenage lymphedema patient, whether they're how much they are able to grasp early on. Are they asking questions? What is that experience like?
Well, I think.
I'm sorry. Go ahead.
So I was just going to jump in and say, I see a fair number of these young ladies. And so to add a little bit of clinical background and scenario, typically we see there are several scenarios. You have the truly primary lymphedema patient who could be a young 16-year-old girl who was born with primary lymphedema, has been dealing with one or more swollen limbs since birth. But in this particular scenario that we've presented, I think more of the lymphedema precox type patient who develops lymphedema at a really critical period of time that I think Dr. Austin would want to discuss. It typically occurs right after the onset of puberty and the first period and so forth. And this is obviously a very emotionally challenging time for young boys and girls going from childhood into adulthood. So there's a lot of body changes happening, some obviously normal, and then in this case, an abnormality that can be fairly subtle in the beginning. And so one of the things I would bring up, Dr. Austin, and have you address is the subtlety of this disease at its onset can sometimes lead to, I have seen in my practice, one of two common scenarios. One is one where the child herself or the patient herself, a young teenager, let's say 12, 13, 14 years old, is not aware of this change, doesn't recognize the change, but it's typically a mother who brings her in saying sort of, "Oh my goodness, what's going on with my daughter? Look at her legs." And the patient herself is saying like, "I don't really see much. I'm okay." And then the other side of that same coin is the child is saying, or the patient is saying, "Oh my goodness, look at my legs." And everybody else is saying, "There's nothing wrong with your legs. Your legs look fine to me." So it's a very critical time in development, as you mentioned, both physically, mentally, emotionally, psychologically. And this extra element of lymphedema precox on top of that just complicates a very complicated period of time.
Yes, isn't that the truth? I just did a podcast actually on gender dysphoria, in which we're talking about the explosion of gender dysphoria in adolescent girls. And as we were talking, I was reminded of all the young girls with anorexia and multiple personality and all of the stuff that can happen to girls at that age because they're so impressionable. They're so sensitive. I remember being that age and being a real pain in the neck to my mother because the hormone fluctuations are so extreme, and you're breaking away from your family on the one hand, and yet you're not really settled in with your peer group on the other. It is a very, very, very vulnerable time. I think a couple of things. One is that I observe generally with people that getting used to a new diagnosis is the hardest thing. That transition from feeling perfectly normal and healthy to all of a sudden you have a diagnosis of some sort, whatever it is, cancer, diabetes, lymphedema. That is really hard, and it stays hard for a while. And then remarkably, people do make an adjustment. And in just thinking about that transitional period and those two scenarios, John, my inclination would be to closely follow along with what the teenager herself is expressing. So, in other words, if she is one who is in denial and she's not seeing anything, I would not particularly suggest pushing her to accept this and to come out of denial. But to rather honor her need to take this very slowly. I mean, she will understand it sooner or later, surely, but psychologically, it sounds like in that scenario, she has a need to be in a state of denial that may serve her well, actually, for a while as she's trying to understand what this is all about. It's a very different scene than someone who is very anxious about this and who may want a lot more information, in which case focusing more on what can be done, whatever treatments you have to offer and so forth, and is much more important. But again, to follow the lead of the patient. The other thing that I would really suggest, tell me first, in a scenario like that, typically, how often do you see the patient after that initial visit?
Well, yeah, that's a terrific question. I'm going to add another, I think, very interesting and challenging element to this particular situation. One, especially as a vascular surgeon, as you know, being married to a vascular surgeon, and Jackie's worked with vascular surgeons her whole career, and Monica's married to a vascular surgeon. Vascular surgeons are very keen on the idea of fixing things. That's one of the things that's attractive about vascular surgery compared to other areas of surgery, which are that, not that things are curable, but things can typically be made a lot better with a good operation, a good procedure, a good intervention, etc. And as a surgeon, you feel somewhat handicapped in the sense that you know that this is a chronic progressive disease, but what you don't know, and this is one of the challenges, you don't know what's going to happen to that patient. Many patients will progress imperceptibly or not at all. They'll have mild lymphedema after the onset of their menstrual cycle, and they'll go through life like that. Other patients, as we've had some guests, real guests on the show, and I can name because they're out and discussing this, and they are advocates for lymphedema and so forth, like Cam Ayala, who to his own admission dismissed his lymphedema for a great number of years as a young person and wanted to play sports, and he didn't want to wear a wrap, and he didn't want to really subject himself to the hard work that was keeping his lymphedema in check. And Cam's story ends tragically where he loses his leg above his knee as an adult man, after numerous infections and a septic joint and a really, really unusual but not unique scenario. So in the back of your mind, as an experienced surgeon in this area, especially, which is uncommon. Most vascular surgeons, general surgeons, don't have great knowledge in this area. It's a big part of the reason why we have this podcast. You don't know how this patient is going to progress, so it's hard to advise them about how aggressive to be in their treatment and care at this very critical time in their life. So it's unlike many other situations where you can be a little bit more dogmatic with patients, a little bit more aggressive and say, hey, listen, you need this triple bypass because if you don't, X, Y, and Z. But with such a young person with such a mild onset of disease, it's kind of easy for everybody to get pulled into the notion that, well, we probably don't have to do all that much because the other side of it is, okay, well, if we're going to pull out all the stops, then you have a 13-year-old girl who you're telling to wear thigh-high compression stockings, 20 to 30 millimeter compression stockings every day of her life to the pool, or wraps and elevation and so on. So it's a very, very tricky, very complicated, difficult situation, not only for the patient, but to some degree, to the clinicians as well.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
First of all, that's true that's total denial and total different hierarchy of values. It's important to acknowledge for teenager, and we just had during the lymphology meeting, we just had the session with discussion around the young kids or teenager, how to deal with them. And that's for sure, like you have the what they want, the little girl will want to be like like another friend, with absolutely no issue. The little boy will say, I want to play football with my friends, and that's his important point. And that's true that we have to listen to them. But on the other side, like we had several cases and several witnesses with the physician who were on that light side, because it's not important edema in the beginning. So say, oh, that's not a problem. You wear compression and you will have it on all your life. And, leaving this young person totally in limbo because they don't know what that means. They don't feel the consequences. They don't know how to do, they are not guided. They are simply not guided.
I don't see how you could possibly navigate that other than with repeated visits. And I know that this is we work in a medical system that in many ways is broken and doesn't necessarily support that. But to the degree that one can have repeated visits, I think that's really helpful. And to think about ancillary psychiatric social workers, for example, therapists who can work with you and really come to understand these issues that you're describing, because you're right, they are very different from a typical scenario. It's not like having cancer or diabetes. It's very different. And that has to evolve over time. I think that's what you're saying very clearly, that the child is evolving over time, the disease is evolving over time. You don't know what the future holds. And you were just explaining, I think that, some denial for a while is okay, but there could come a point when that could really create problems. And so to be gradually working with that child as they grow up to help them take greater responsibility for their health is a really important thing. Incidentally, it happens that tonight I'm having friends over for dinner, and the woman has had lymphedema her whole life. I have never known her not in compression stockings, and she's had a magnificent life, married to a wonderful man and so forth, and is a tennis player too. So, it's an example, I think, of the best case scenario. So there is that. And as physicians, I think too, especially in those early stages, to offer hope and some buoyancy and some optimism is important, while also making the case that you're a team and you're going to stick together because this is serious stuff.
Yeah, I think that's all great. And we could go on and on about this for hours because it's such an important subject. We do have a couple of other scenarios we want to get to, but before we do, I want to invite Jacqueline to make any comments or ask any questions, because I know she has a teenage daughter who I think is around the age going through the changes of life into adulthood, and probably dealing with this personally at the time, not in the scenario of lymphedema, but probably aware of how challenging a time it is. Jackie, do you have any thoughts before we move on to the next case?
Question. So I'm thinking the opposite end of the spectrum. I had a friend when I was in high school who had lymphedema, and it was kind of an obsession for her. Her diet, her exercise, her life almost became the condition, and she didn't have a social life. She missed out on a lot of it because of, I'm calling it an obsession, for lack of a better word, but she was consumed by the condition. So in that scenario, how do you help somebody like that?
As we're talking, it would seem to me that it would be so useful for clinicians such as yourselves, who see a lot of these patients, to develop a relationship with one or two therapists, not necessarily psychiatrists. I think psychiatric social workers often do give magnificent care and are very well trained, but where you really help that person become an expert in all of these things that we're talking about, so that you then have a referral source for whichever end of the spectrum you're dealing with, whether it's that teenager who is in total denial, or the one who is overly preoccupied and everything in between. As vascular surgeons and as vascular medical specialists, I seriously doubt you're going to be spending an hour a week with your lymphedema patients doing psychotherapy, much as that might, be very nice, but you don't have to, but somebody could. But I think that to think about getting somebody in the community that you rely on, I would think that there would be therapists who would be really interested in working with you on that, and could be a great adjunct to the team.
I think that's phenomenal advice. And I'll just end this segment before we move on, only because I'm so eager to touch on the others, because I know we have so many listeners who will also find those scenarios important. Hopefully, as Dr. Austin mentioned, we're working with a medical system, and we talk about this again and again on the program. Not that I have the answers, or any of us have the answers, but it's fairly obvious that the system is quite broken. Hopefully, one of the things that is going to be a reparative stitch in the fabric of American healthcare is this the new LTA, Lymphedema Treatment Act, which was recently passed and will be helpful, at least in patients being able to hopefully afford compression garments and things like that. But I think people like Monica Glavitsky and people like Emily Eicher, and I would count myself and Jackie amongst them also, would hope that we're moving toward a time where in the United States we have a dedicated specialty of lymphology, and that the lymphologist could be the quote unquote, for lack of a better term, quarterback of that multidisciplinary team that these patients need. And we talk about that again and again on the program, that there's no one individual clinician who is going to be able to fully treat this very complicated problem. So vascular surgeons will need to be involved in some cases, but certainly lymphedema therapists, physical therapists with experience in manual lymphatic drainage, compression, elevation, psychotherapy, emotional therapy and support, nutritional education, diet, exercise, and on and on and on. This is such a complex problem that we really need a lymphologist who has the time, the expertise, the knowledge, and can put all of these resources together. Monica, would you like to comment on that?
Well, we are just coming from the Congress that was discussing the issue, and we had a group of European colleagues that even were discussing, because they wanted in the very beginning to maybe to do something with the phlebologists, so it will be like phlebo lymphology specialty. But phlebologists are not very eager to join the team. They are more focused on the veins, and everybody agrees that you need expertise in this field, but nobody agrees how to create the specialty or subspecialty. And look what we are going through in the United States with the vein treatment. You have a board, but it's not really a true board, and it's very, very complex. And I don't have the answer, and it doesn't look like the people have the answer for it now.
But again, great points to Dr. Austin's statement, which is absolutely 100% true. There's no vascular surgeon who's going to spend an hour a week or an hour a month or an hour a year with these patients. Generally, unfortunately, that interaction will be a few minutes, and it will be, there's really nothing I can do to help you. If you don't have, let's say, underlying venous disease or some other surgically correctable problem, you need to wear compression and elevate your legs, and that's it. And so sadly, tragically, and that's why we're here on the program, the vast majority of these patients, I would say, still are being more or less dismissed and discarded, and are pretty much on their own after either a primary care doctor, doesn't matter whom. No one really has the expertise, the bandwidth, the desire, the financial incentive, etc., to care for these patients. And it's a major problem.
Would there be a role for the physician extender in the office to meet on a semi-regular basis, at least once a month or something like that in the beginning? Would that be feasible?
If the physician extender has expertise in that area, but extension of whom? The extension of the lymphologist would be the perfect person, somebody who really understands what's going on. But most physician extenders, quote unquote, mid-levels, whatever you want to call them, they're working for and with people who have limited knowledge, expertise, and so forth. So yes, that would be ideal in many ways. But we have found that in many cases, the most capable people right now in the United States, at least in my experience, have been people like Monica was just with Anna and Oscar Pizzoli from here in New Jersey, who are physical therapists. So there are many physical therapists who have become intensely interested in lymphedema and the management of lymphedema, and sort of work to some degree, in many cases, under the auspices of a physician, that the physicians have to write orders. Like myself, for example, we work closely together. They write orders for treatment plans and so on and so forth, because the physical therapists in many cases are not in a position to do that. But I think that's the greatest hope right now in the short term, is for physical therapists who have real training, real interest, and then develop a relationship with an MD in their community who takes an interest.
Well, the other thing we should have in mind that there is certainly maybe specifically for lymphedema patients, the value of lymphedema clinic. Like we have the part of the Mayo Clinic consultation devoted to lymphedema, and that's the optimal situation, because this is a multidisciplinary team with all aspects covered. But this is in a way I always consider that it's a luxury situation, And I don't see many of other examples of such a well-organized clinic in another medical structure in the United States.
I think big university programs and teaching programs and so forth would be the ideal place to start this kind of thing. And I think in many cases, they may have the resources to put that together, maybe as a division of the Department of Vascular Surgery, maybe as a division of the Department of Internal Medicine. But in either case, you may be right that the best place to get this started is in reputable academic centers where they have the resources to really care for these people. With that, I'm going to multidisciplinary for sure. Yeah. With that, I'm going to press on to the next subject because otherwise we won't get there. As I said, we could go on forever. Let's talk about scenario 2. Again, fairly common, but this is a made up patient, so to speak, a conglomerate of people that we've all seen over the years. So patient 2 is a mother with, let's call her 36 years old, with stage 4 breast cancer, now in partial remission, who's focused on her lymphedema. This would be presumably upper extremity lymphedema after some sort of breast resection of the primary tumor, either mastectomy or lumpectomy, with lymph node biopsy/dissection. These biopsies and dissections are getting less and less invasive over the years as we have sentinel node and so on and so forth. But nevertheless, patients still develop lymphedema in some cases, and it can be fairly dramatic in some cases. But we have a 36-year-old mother, stage 4 breast cancer, partial remission, and now becoming very, not only focused on her lymphedema, but also, to complicate the case, apparently this patient is in denial about her cancer. Dr. Austin?
Yes. I did some reading of the literature, and there are large studies that are looking at the psychiatric follow-up of women in a scenario like this. And actually, I was impressed that, yes, they have increased rates of depression and anxiety. And now I'm referring just to those who are thinking about their lymphedema, not the stage 4 cancer. But they're in a much stronger psychological position because they have some life under their belt. Presumably there is a spouse, or there are children, or there's work, or there's a structure, and there's some maturity that is very helpful. I've been struck with cancer patients by how much the cosmetic aspects of surgical care or oncologic care really matter. So one might think, gosh, if you have stage 4 cancer, would you really be worried about losing your hair? Would you really be worried about your arm? Would you swelling? But they are. And why is that? Well, it's what you can worry about, right? I mean, you can't do a whole lot about the stage 4 treatment other than go along with what your oncologist said. But you can think about your wig, or you can think about your arm, or that is something that I think is not uncommon to focus on, even though it may seem surprising to the clinician who thinks, gee, this person has bigger fish to fry than, let's say, the lymphedema if they're only in partial remission. So, again, I think I would listen very carefully to the patient. Maybe they need to be in denial about the cancer. I think that so long as patients are going along with their treatment, the denial can help them just not lie awake at 3 a.m. and think about their children, or what's going to happen, and because they have to have a certain amount of denial.
Lynn, I want to comment on that. This is an amazing discussion because you brought to mind, and Jackie may actually remember this patient. I'm sure she does. Jackie worked with me as the director of my vascular lab for many years. This is an amazing story. I had a patient who was the mother of children who went to school with my children. And she was a beautiful young woman in her early 40s at that time, I would say. and she developed pancreatic cancer. And she was treated at Columbia Presbyterian. I'm just outside of New York City. She was treated at Columbia Presbyterian, had excellent care. She was, a very well-to-do woman. She had great insurance coverage. She had all the resources in the world. She got great care for her pancreatic cancer, had a Whipple procedure and adjuvant therapy and so on and so forth. And she also had terrible varicose veins. And she came to me. The reason I think this is such a fascinating situation is not only because of what you just said now, but what you said earlier about the patient with cancer that everybody says, I forget the name you use, let's say Gina. Oh my God, Gina, how are you? And you become Gina, how are you, rather than Gina. So it's very apropos to this situation. So she came to me and she wanted me to treat her varicose veins. Jackie, do you remember what I'm talking about? Yeah. And my initial reaction internally was, there's no way. That's completely unethical. You have pancreatic cancer, and I know the long-term outcome and results and so forth and prognosis of pancreatic cancer. Of course, she was in remission at the time. And my initial response internally was, no way am I going to treat your varicose veins. But her varicose veins were really bad, and she was a beautiful woman, and they were highly symptomatic. But she was also like the teenager, and like any normal human being, she wanted to be like her friends too, her peer group too, that she was back playing tennis with and golf with and so on and so forth, as she was feeling better.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
And she didn't want to walk around with these painful, unsightly varicose veins. So I did what every self-respecting surgeon would do, is I punted it. I said, well, if you can go back to your surgical oncologist and your medical oncologist and so forth at Columbia Presbyterian and get clearance for varicose vein treatment, I'll be happy to do it. Right? Knowing full well that they would say, this quack from New Jersey's out of his mind. No, you're not having varicose vein surgery. And to my, I wouldn't say dismay, but to my surprise, I got two beautiful letters in the mail saying there's no reason that you can't treat her varicose veins. Go ahead and treat her. And I have to tell you, I did. And I have to tell you, she lived about 4 years. She had a very good, and unfortunately later we lost her. She passed away. But for about 4 years, she was great. She was healthy. She felt great. She played tennis. She played golf. She saw us every 6 months in follow-up. And she was so appreciative. And it was a great learning lesson for me, not to. Now, of course, again, if she were in treatment, if she were, on a downward spiral, I would have never have treated her. But it was a great learning lesson for me because she was not in that place, either physically or mentally. She had been treated, she was in remission, and she wanted to go on with her life. And I was really not in a position to stand in the way of that. Do you remember, Jackie? Yeah.
So she would say, okay, I have stage 4 cancer, but I still want to have beautiful legs while I'm still alive. Let me please.
And pain-free legs.
And pain-free legs, yes.
Right?
Yes.
That's right.
And I treated her, and she did very well, and she lived for a number of years, and she was very happy, and she used to come in and say how happy she was that we did it and how appreciative she was. And I really learned a big lesson in that case.
Yeah.
I think that's very important in what you're saying. Now, third case, a man with lymphedema who has discomfort and pain, we're going to assume, in a significantly lymphodematous lower extremity has become addicted to alcohol and, I'm going to say, and opiates as a result of, let's say, self-medication and medication he's received from his physicians during the course of his illness.
Yeah. Yeah, I did come up with these scenarios, didn't I? Why did I give give myself such hard ones?
If I were going to give myself a test, I'd make it much easier than this.
Well, wait a second, John, because actually so many female patients in denial that we know went through a phase of alcohol, the abuse and just let it go. It's just the whole phase before they started to treat themselves seriously. That was like, I don't want to understand, I don't want to know, I don't want to feel. It's just let it go with alcohol.
It's not uncommon.
I have to say that when in my psychiatric career, I have missed an important diagnosis, it's always been an addiction, because those addictions can creep up and hit the people that you least expect, who may seem like the opposite of whatever your own personal stereotype is of a substance abuser. But especially, of course, somebody who has chronic pain is going to be at very, very high risk. The advice is very simple. That person has got to get to a substance abuse specialist. I'm a general psychiatrist. I don't consider myself a substance abuse specialist. They are a particular breed. They're very well trained. They think about things differently. They listen differently. When I see my psychiatric patients, I always assume that they're at least trying to tell me the truth. Substance abuse and deception, self-deception and deception of others go hand in hand. And substance abuse experts are really expert at sussing that out. The other comment I would make is that there have been some real changes, I think, in how we think about both, certainly alcohol, obviously the opiates. The recommendations now for alcohol consumption are so much lower than they used to be. My friends hate me now because I did a podcast in which I talked about the National Institute on Alcohol Abuse is now calling heavy drinking, which they define as a level of drinking that damages your brain or your physiology, your body, your liver, et cetera, as more than 1 drink a day for women, more than 2 drinks a day for men. So in other words, more than 7 a week for women, more than 14 a week for men, more than 3 in any one setting for women. So in other words, it's more than 7 a week or more than 3 in one day for women, more than 14 in a week, more than 4 in one day for men. So that's quite low. There are medications now that can be very, very, very helpful. Naltrexone, for example, is a medication for alcohol abuse in which a person can drink, but they don't get a buzz from it. So they will find it easy to drink a glass of wine or 2 glasses of wine. You would think that would be a panacea. It's not, because it turns out that the reason people drink more than a glass or 2 is not that everybody thinks and everybody says, well, I just love the taste of a fine glass of wine. No, not really. I mean, you may, but you're really going for the buzz. And so naltrexone is not quite as useful as one would expect. And obviously the issue with the opiates is even more difficult, but they certainly need to be withdrawn under medical supervision. I am of the opinion that after a period of years in which, when I was practicing in Maine in the early 2000s, like 2001 to 2004, I was shocked, frankly, by how opiates were passed out like M&Ms. Now we've swung to the opposite extreme in patients who I think desperately need opiates where it's really indicated can't get them. And surely there's got to be something in between. But again, I think this is a good reason to have to know what your substance abuse treatment programs are in your community to get help with this, because it's such a common problem.
I couldn't agree more. It's interesting, this whole idea of self-medicating and the numbers that you're giving us in terms of drinks. I have a friend who's a great guy, in great shape, great physical shape, and he's a money manager. And he called me one time to say that he had gone to see a psychiatrist, not a psychologist, but a psychiatrist, because he was having some personal problems and so forth. He wanted someone to talk to. And the first thing that the psychiatrist, one of the first things that he asked him in their first consultation is, how much do you drink? And he told him how much he drank. He was drinking about a bottle of Chardonnay every night. And totally functional guy, worked every day, has a great book of business and so on and so forth. And his response was very interesting. The psychiatrist said to him, we have much better medications than that.
Well said.
Yeah,
well said. Yes.
And he was like shaken up by it. He called me and he said, do you think I'm self-medicating? He says, I said, that's what everybody does, with alcohol. It's nice to say, oh, it's a great bottle of wine, it's delicious. Years ago, I went to a very nice restaurant, and there was a sommelier. It was a fancy place, and he said, look, ultimately, wine is a beverage that gets you drunk. I mean, that's why it's been imbibed for 3, 4, 5,000 years. So this idea of, as Monica pointed out, very, very easily kind of slipping into this scenario of self-medication is very easy to do. It's extremely common. It's definitely underdiagnosed, and it's overlooked. And I think that, like many patients with chronic disease, and certainly with chronic pain, the lymphedema subpopulation would be no exception to that. And then, of course, the thing that we're seeing, and that's a whole other show that I'm sure Dr. Austin has already had the show on, or several shows on, which is the generalized acceptance of marijuana now, and the role that it plays in medicinal marijuana versus recreational marijuana, and where those two things overlap is becoming increasingly, at least in my experience as a surgeon in the community, increasingly an obvious problem.
It is an obvious problem. I was talking to a friend who was a pediatrician, and she was saying in California, where they are, there are people who are stoned from the moment they wake up in the morning till they go to bed at night. Of course, it's addictive. It's quite addictive. And, the brain is my favorite organ. I mean, I think the brain is kind of a great thing, but you gotta take good care of it. And these substances of abuse are real problems. And especially, I think those who have chronic illness are certainly at higher risk. And I would say also really deserve the most compassionate approach, the most empathic approach, but also the most firm approach in getting them into an expert who can help them and who can really follow up on that, because it never makes anything better.
Yeah, well,
and it's epidemic. It's epidemic.
Actually, specifically for lymphedema, it makes it so much worse, because there is the activity of the alcohol, not only on the nervous system and the brain, but also, this is very nocive for the whole body, and it's worsened the swelling.
Yeah. Yeah, Jackie, again, knows we have a patient who's been in my practice for years, a wonderful guy. I'll call him John R. John R. is an adolescent psychologist, and he has written several articles, academic articles, on what he calls, he doesn't play it down when he writes, but I'll play it down with the show. He calls it the F-its, F it. And he says that a lot of the adolescents, whenever something comes up, which is a stressor, they say, F it, I'll just get high instead. I have an exam coming up, F it, I'll just get high. there's, tryouts for the football team and I have to run laps and do push-ups, and I'll just get stoned instead. So and he's seeing it as a major, major problem. It's just so easy to say, F it, I'm just going to get wasted. I'm just going to get high, just going to smoke a joint. And there's so much access now, and it's being so positively reinforced by, I hate to say this, but mainstream media, social media, et cetera, et cetera. And I think it's a very dangerous thing. That's the first thing I would say. The other thing I would say is I agree with you, Linda, when you say the brain is your favorite organ. Now, I'm a little biased because my wife has a PhD in neurochemistry, and I think it is an amazing organ. But one of the things that I think makes the brain such an amazing organ, besides its own complexity, infinite complexity and plasticity and so on and so forth, is the fact that I think it's the only organ that I'm aware of, as I'm a cardiac surgeon, vascular surgeon. I've operated on just about every organ in the body, including the brain, with colleagues of mine. I think the brain is the only organ that's not just the brain, but it's also the mind. Mm-hmm. A kidney is just a kidney. A heart's just a pump. We don't feel emotions in our heart like the ancient Greeks thought. It's coming from our mind. And that's unlike any other organ. And I think that that's what makes having a guest like you today so fascinating, because we're looking at a 3-pound organ that sits in our skull, but it's much more than just an electronic and neurochemical switching station. We have a mind, and where the brain ends and where the mind begins, that's a partially philosophical discussion, partially scientific discussion, but it really makes it a unique area of study. And that's why we have neurologists and psychiatrists, because and where those lines get drawn is becoming more and more vague and so forth. So it's a fascinating subject. It's been a fascinating discussion.
Could I just throw one more thought into that, though, John, which is years ago I went to a day-long seminar on evolutionary psychiatry, and the gist of it was, well, how has natural selection created this mind brain in the way that it has? How do we understand it? And the presenter, his name was Randy Nesse, who's out of Michigan, I believe, said, well, camouflage is ubiquitous in nature. Human beings have to camouflage themselves from each other because we live in such tight, small, dense social structures, and we have to constantly hide our true feelings from each other. So I can't say to Monica, for example, Monica, how come you have those pearls and I don't? I want your pearls. Instead, I say, Monica, what beautiful pearls you have. So we're always camouflaging. And he said, and what better way to fool other people than if you fool yourself first? So the unconscious has developed as a way of fooling yourself about what's really going on. So I have no awareness, let's say, of being envious of the pearls. I'm only aware that I think they're beautiful pearls. And we've been talking a lot about that in some sense today with denial, with the way the brain works to try to fool itself, sometimes adaptively, sometimes worrying about varicose veins because the thought of having pancreatic cancer is just too overwhelming and too terrifying. And the mind brain does have these wonderful ways of self-fooling that sometimes help us out a little bit.
Yeah,
so
beautifully said. Well, as for many of our guests, especially your friends, Monica, I have to say it again. We'd love to have Dr. Austin back anytime. So many scenarios to go through and so many important subjects to discuss. And I think this was a discussion which has been long overdue. In fact, it's always been my desire to have a full-time therapist, psychologist, psychiatrist on the program, on the panel, because I do think that the psycho-emotional part of this disease, like many chronic diseases, but this is a special disease in many ways, is hugely important. And it's not going to be fixed by a distal bypass graft or a stent or an amputation or any of those other things that the surgeon community leans on so heavily. This is going to take a multidisciplinary approach. and a really, really dedicated and fairly extensive team of experts to help these people to live their best possible life in a situation which is unfortunately incurable, but is much more manageable than the job that we're doing now as healthcare professionals. Much more manageable and much more treatable. So that remains our goal. And I thank you for your being with us today. I thank Monica for going out of the way, for being here from Warsaw, and Jackie, as always, she's a stalwart. So, Paul, if you want to take us out, I think we're all set.
I sure will. We should put a plug in for Dr. Austin's podcast. Is that the one that's called "They're Driving Me Nuts"? Is that the name of your podcast?
Indeed, it's a podcast about the soul-sucking situations of everyday life.
If we're going to do shameless plugs, that's not a shameless plug, but mine is. I want to mention my book, Make Your Own Damn Cheese, where I talk about the conscious mind, subconscious mind, and superconscious mind from the point of view of a non-psychologist, non-psychiatrist, non-expert, but just based on many years of study and research I've done in that area. And I hope Dr. Austin would read it. I'll send her a copy of
I'd love to see it.
Make Your Own Damn Cheese. And one more plug for Monica Glavitsky's amazing website, where we can see her beautiful artwork. Monica?
Well, I invite you to my website, which is Monica with K, L, Glovitsky, GLOVICZKI.com.
Right.
And see if you like it.
I have several of Monica's paintings, and they're our favorites. They're awesome.
And so
really awesome.
I agree. And I will, Emily's not here today, but we're going to mention the Lymphedema Center in Santa Monica, California, for anyone looking for a really experienced, really devoted lymphedema specialist and lipedema specialist in Santa Monica, California.
Thank you for the pleasure of being on this podcast.
All right, let's go around and thank the whole panel from Arizona, Dr. Monica Glavitsky. At least that's where she lives. That's not where she is now. But Dr. Glavitsky, yeah, thank you very much for being here.
Thank you. From Arizona, transferred to Warsaw, Poland.
All right. And Dr. Glavitsky, would you take a moment to thank Dr. Austin for us?
Absolutely. Linda, that was delightful. And I'm so glad that you accepted. And I hope that this is the first of the many times of your presence of this Lymphcast.
Well, I never saw a microphone I didn't like, so who knows? It could happen again.
Right. Also from New York, RVT, Jacqueline Sasek. Jacqueline, thank you very much.
Thank you, Paul. Thank you, Dr. Austin. And I'm going to piggyback what Monica said. Hope to see you back very soon.
Thank you.
As long as we don't drive her nuts, she'll be back. Right? Tagging onto her podcast. The founder and owner of Vita Support MD, they make Vein Formula 1000 and Lymphatic Formula 1000. Also the founder of this show, Lymphcast, physician surgeon from New Jersey, Dr. John A. Chubak. Dr. Chubak, thank you, sir.
Thank you, Paul. As always, a great show. Thank you again, Dr. Austin. Thank you to everybody. Monica Glavitsky and I and Emily Eicher and the rest of our team will be at the American Venous and Lymphatic Society meeting in the International Union of Phlebology next week in Miami. So we'll be together and we'll learn as much as we can, and we'll share our ideas with others and absorb as much knowledge as we can, and hopefully bring that back to our listeners in the near future to share what's happening new in the world of lymphedema, venous disease, lipedema, wounds, and so on and so forth. So thank you all very much for tuning in. I really appreciate it.
All right. Thank you, sir. And again, you've been watching Lymphcast, episode 32. We thank you for listening and or watching. You can find us on YouTube. Every episode is up there. Also, the podcast world, Google Podcasts, Apple Podcasts, TuneIn, Stitcher, Spotify, Amazon. We are all over the place. Remember to visit our website, lymphcastnetwork.com, and send in your questions for the panel. hello@lymphcastnetwork.com. Again, the Lymphcast Show, episode 32. Have a great night. We'll see you next time for episode 33.